I'm going to show you the proper technique in testing pupils. So we always test patients' pupils before we put dilating drops in their eyes, and that's because any issues with pupils can be a sign of more serious eye conditions, and obviously we need to test the pupils before we put in dilating drops, because once the dilating drops go in, we can no longer assess the pupils anymore. So you want to start by instructing the patient on what test you're going to be doing. So I'm going to be testing your pupils and testing how your eyes react to the light. So you want them to remove glasses if they have them, and then have them look at a distant target far away. It's important when you're doing testing for pupils that the patient is always looking out at the distance. You never want them looking at anything up close, because that can alter how the eyes react to light. Okay, so look straight ahead for me. You're going to use what we call a transilluminator, which is just a small flashlight. And what I usually do is, when you turn it on, you push down the little button, turn it to the side. I turn it all the way up to the brightest setting first, and then come down a little bit. With most patients, you don't need the absolute brightest light, and it's very uncomfortable for patients if you're shining a very bright light into their eyes, and sometimes it can make it hard to assess. So I would first turn it all the way bright and then come down just a touch on it, just so it's not too bright for the patient. So I'm going to have you look straight ahead. You're going to hold the light approximately 2 to 3 inches away from the patient's face. You don't want to be in too close. You also don't want to be too far away, because if it gets too far away, then the light, when you want to direct it into the right eye, can actually end up getting into the left eye as well. So you want it close enough where the light is only being directed into the eye that you're testing. So 2 to 3 inches away, and you're going to start off by just assessing the right eye, and you're going to look twice, minimum of 2 times, in each eye. So you're going to start with the right eye. The first thing that you're looking for is, when you direct the light into the pupil, is, first of all, is the pupil round. The pupil should be round in shape. It shouldn't be oval or have any type of irregularity to it. It should be perfectly round in shape. The other thing that you're looking at is, when the light shines in the pupil, it should constrict. So it's called the reaction to the light. It's called the constriction. So when you shine the light in, the pupil should go from being larger to being smaller. Okay, so those are the first 2 things that you're going to look for. And in order to assess that, you want to hold the light in front of the eye for about 2 seconds. So 2 to 3 inches away from the eye, and hold it in front of the eye for about 2 seconds. Right eye first, and then left eye. So I'm just going to show you that. So Braylon, look straight ahead for me. I'm going to look in. I see it's round. I'm going to pull it away. I'm going to shine it back in the eye for 2 seconds, and I see that it's constricting from the light. Then we go over to the other eye. 2 to 3 seconds, take it away. 2 to 3 seconds, and take it away. And you notice I'm standing to the side. I'm not here, because if I'm in front of her face, then she can't see the target at the distance. So she's got to be able to maintain that fixation far away. Okay, so that's the first part of the testing, is just each eye individually. Is the right eye the pupil round, and is it reacting to the light? The left eye is the pupil round and reacting to the light. Once you have that established, you move on to kind of the second part of the pupil testing, which is comparing the reaction between each eye. And you're looking for something called an APD, or an afferent pupillary defect, which just means one eye is not reacting to the light as well as the other eye. Okay, and the way to do that is, you need to now compare the reaction of one eye, of the right eye, to the left eye, and you do that directly. So what that involves is shining the light in a similar manner, about 2 to 3 inches away from the eye, and you're going to hold the light there for about 2 seconds. But this time, you're going to direct the light into the right eye, and then after 2 or 3 seconds, once you observe that constriction, you're going to immediately go over to the left eye, and you're going to observe the constriction in that eye. And then you're going to go back to the right eye, and then you're going to go back to the left eye. So it should be a minimum of checking that 2 times back and forth, to make sure that whatever the right eye is doing and how that constriction looks, when you move it over to the left eye, it looks exactly the same way. They should be doing the same thing. And everybody's eyes and pupils will react a little bit differently to the light. You'll notice some pupils just constrict and stay there when you shine the light in. And then when you remove it, it opens up. When you shine it in, it constricts. Other patients, you'll notice it constricts and then kind of moves around a little bit when you shine the light in. So really, as long as it's doing the same thing in both eyes, that's usually normal, okay? What we're looking for is if you shine the light in the right eye and you see constriction, and then you move it over to the left eye and the eye starts to dilate. Now the two eyes are doing opposite things, okay? The right eye is constricting when you shine the light in, but when you move it over to the left eye, it opens up, okay? That means that there's a problem with the left eye, and that's really what you're looking for, okay? So this part of the test, how this works is, again, you know, they're already should be looking straight ahead because you are doing the initial assessment of the pupils, so continue to look straight ahead. I'm gonna shine right eye, 2 seconds, left eye, 2 seconds. Right eye, 2 seconds, left eye, 2 seconds, okay? And when I'm going back and forth, I'm looking at the pupil constricting, 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 okay? So any abnormality that one eye is doing differently than the other, that would be a concern, okay? So basically with pupils, if you see any irregularity in the shape, in the size, if one pupil is bigger than the other one, they might both be reacting the same way, but one is very large and one is small. That would be concerning. Or a difference in the reaction between the two eyes. That's when you want to make sure that you notify a doctor to come in, double check it, and see what's going on. The other thing you want to keep in mind is a lot of people who have differences in their vision between the two eyes, in those cases, there is oftentimes a pupil abnormality. So if you get a patient who comes in who's either a new patient or maybe an established patient and it has a change in their vision where one eye is seeing well and the other eye has reduced vision, you really want to have a doctor come and double check those pupils, especially if it's something that's different. Say last year they were 20/20 in both eyes, this year you come in they're 20/20 and 20/50 or 20/100. It's really important to assess the pupils in those patients because obviously they have something going on in that eye, and we want to make sure that the pupils are normal because that can really give you a lot of information as far as what might be going wrong with that patient. So one more time, I'm going to wrap it up. I'm just going to show you the test again, and then we're all set. So you just tell the patient, I'm going to test your pupils and see how your eyes react to the light. Keep looking far away in the distance. I'm going to do each eye individually for about 2 seconds. And then I'm going back and forth, directly over for about 2 seconds in front of each eye.
Hi, today we're looking at relative afferent pupil defects, or RAPD. This is also sometimes referred to as Marcus gun pupil. First, we will compare its clinical appearance with that of normal pupils and also that of a complete afferent pupil defect. To avoid pupil constriction whilst accommodating, ask the patient to fix on a distant object throughout your examination. Look for equal pupil sizes and check again with the lights off. Anisocoria is not a feature of an afferent defect. Now check for a reaction to light in each eye, again with the lights off. Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed. Now swing the light from eye to eye, quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them. Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slower response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here, the left side is affected. You will miss an RAPD if you do not do the swinging light test, as it is only by comparing the relative strengths of the signals reaching the brain from the eyes that the abnormality is detected. Finally, with a complete afferent pupil defect, there is no pupil reaction to light shone on the affected side. Due to crossing of nerve fibres at the optic chiasm, an RAPD localises pathology to the visual pathway before the chiasm, that is, the optic nerve or retina. Some examples of pathologies causing an RAPD are large retinal detachment, central retinal artery or ischemic central retinal vein occlusion, optic nerve ischemia, optic neuritis, optic nerve compression, or asymmetric glaucoma. It should be noted that an RAPD is not caused by either cataract or vitreous hemorrhage, and when associated with amblyopia, it is usually mild. Therefore, a definite RAPD in these cases should prompt to look for another cause of visual loss. To criticise, comment or share your knowledge with others, please go to ivideos.blogspot.com, where you will find transcripts, links and more videos.
Today we will be learning about and evaluating relative afferent pupillary defects. In the assessment of the pupillary light pathway, both the direct response and the consensual response are tested. When a bright light is directed into the eye, both a direct response and a consensual response occur. If there is complete damage to the afferent pathway, no direct or consensual response will occur for the affected eye. This young normal patient shows a brisk, direct and consensual response in both eyes. The afferent pathway begins when light enters the eye. A neural response is triggered in the retina, which exits the eye through the optic nerve. Nasal retina fibers cross at the optic chiasm, while temporal fibers continue to the ipsilateral optic tract. Pupillary fibers exit in the posterior third of the optic tract and travel within the brachium of the superior colliculus to an area of the midbrain known as the pretectal nucleus. Synapse occurs and the fibers leave the pretectal region and travel to the two Ettinger-Westphal nuclei, distributing about equally to both. The efferent parasympathetic fibers exit the Ettinger-Westphal nuclei and head to the ciliary ganglion. From there, they enter the eye via the short posterior ciliary nerve and cause pupillary constriction. This pathway is evaluated using the swinging flashlight test. The patient is asked to fixate on a distance target while the practitioner swings a light from eye to eye several times rhythmically, taking care to illuminate each pupil for an equal length of time, approximately 2 to 3 seconds. This video shows a normal patient with no APD. Next, we will evaluate a patient with an abnormal pupillary response. This patient had laser surgery to correct an idiopathic retinal hemorrhage. Note the macular involvement as well as the proximity to the optic nerve. We begin with direct and consensual pupillary testing. Note that a direct and consensual response are present in both the right and left eye. This may or may not be the case when an APD is present. Next, using the swinging flashlight test, we evaluate the patient's relative afferent pupillary defect. When the light is shined into the patient's left eye, we notice brisk constriction of both the right and left pupils. However, when the light is switched over to the right eye, we notice significant dilation of both eyes. This is a significant right RAPD. Next, we will quantify the magnitude of the patient's right RAPD using neutral density filters. A neutral density filter is a filter that reduces or modifies the intensity of all wavelengths or colors of light equally. Each step up our neutral density filter increases the optical density through which light is passing prior to entering the eye. Using the same swinging flashlight test as before, we hold the neutral density filter over the patient's better eye, the eye without the defect, while we watch the patient's uncovered eye, the eye with the defect. The endpoint is reached when the light is shined into the uncovered eye and there is no constriction or dilation. This indicates that the magnitude of light entering both eyes is approximately equal. We were unable to reach that endpoint through a 2.0 optical density filter for our patient, indicating a 4+ APD. Next, we will induce a relative afferent pupillary defect on our normal patient using the same principles used to quantify the magnitude on our last patient. As we increase the magnitude of the optical density of our filters, we decrease the magnitude of the light entering the covered eye. This simulates a left relative afferent pupillary defect with increasing magnitude. This same principle can be used for reverse RAPD testing in the event that you are unable to see the pupil due to an opacity in the anterior chamber or on the cornea. Thank you for joining us today to learn about relative afferent pupillary defects. Have a great day.
In this patient, you will see that the right pupil consistently dilates as the light is swung toward it. This dilation is called a relative afferent pupillary defect. It usually signifies that an optic nerve lesion is present on the side of the dilating pupil. This test is the most sensitive and the only objective way to demonstrate a unilateral optic nerve lesion or bilateral but asymmetric optic nerve lesions.